Hello everyone, this is Greg Moody in Governor Kasich's Office of Health Transformation. I'm here with Ohio Medicaid Director John McCarthy. Welcome to this webinar on transforming payment for a healthier Ohio. The purpose is to provide an overview of Ohio's payment reform activities. We've had a very busy couple of months. We got good news at the end of the year that we received a grant from the federal government to pursue this work. We organized and put together the governor's budget and launched that a couple of weeks ago. So we are now ready to put our full focus on payment innovation and move forward with the activities that many of you have helped us get in this very good position for Ohio. The information that we're presenting today is available on the Office of Health Transformation website. And that's available to you to share with whomever you think might be interested in the information. And also at the end of my presentation, we will open up the forum for questions via the webinar toolbar. There is a section there where you're able to post questions, and we will respond to as many of those as we can. To start with, I want to provide a quick snapshot of where we are with the project. Governor Kasich created the Office of Health Transformation to improve overall health system performance 4 years ago. Our goal is to pay for healthcare value instead of volume across Medicaid, state employee, and commercial populations. And we're on track to launch episode-based performance reports in the next quarter. I'm pleased to announce that beginning March 2nd, providers will begin receiving these performance reports, and we'll discuss that in some more detail. Our partners in this effort are Ohio's largest health insurance companies: Anthem, Aetna, CareSource, Medical Mutual, Buckeye, Molina, Paramount, United Healthcare, covering about 10 million Ohioans. These activities build on the momentum from extending Medicaid coverage in Ohio a year ago and other reforms like getting Medicare and Medicaid enrollees into better coordinated care. How did we get here? What are the next steps? That's what we'll cover over the next 30 minutes or so. We'll go in this order. A little bit of information about Ohio's approach to paying for value instead of volume, and then a look at two very specific models we're proposing: patient-centered medical home and episode-based payments, and then go into some detail on one episode so you have more information about how the model works. As a starting point, this is really the value proposition for Ohio. We tend to pay on the high side. Only 17 states, the residents of those states, pay more for their health care than we do in Ohio. And results tend to be on the lower side. 29 states are healthier than Ohio. So we pay on the high side, get results on the low side. We believe this is partly driven by this financial engine that is rewarding volume instead of value. So how can we move away from volume toward better sources of value? In fee-for-service, which dominates our system currently, we get what we pay for: more volume, more fragmentation, more variation, things that I think most of us have come to agree with over the past few years. So how do we reset the reward away from fee-for-service volume toward value? The federal government has been encouraging states to work on this issue and putting out significant grants for states that are willing to function as a catalyst to convene groups of payers, providers, patient advocates to align on new models for paying for value. About 17 states have received these grants to date. Ohio received $75 million over 4 years to test our models. It was the second highest award to a state. Also, fortunately, we have one of only 7 comprehensive primary care sites in the nation. These are federally endorsed sites to look at better ways of providing primary care and attaching payment rewards to that better care. In general, the idea is to take the current fee-for-service model I was talking about before, which if this picture was drawn to scale most of it would be consumed with fee-for-service, with a little bit of population-based payments around the edges, affordable, accountable care organizations, some patient-centered medical homes. But the reality is most of what we spend is in the middle on a few high-cost episodes of care. So how do we transition away from fee-for-service to a population-based model, ultimately through accountable care organizations? But to get from point A to point B, we have to account for most of the spending being on these episodes in between. Our approach has been to use the purchasing power of the Medicaid program as a starting point to propose better models for patient-centered medical homes and for episode-based payments, and then invite commercial payers to join us in changing how they pay so we can align in these areas in a way that creates a coherent set of rewards across payers for providers. We are mandating that Ohio's Medicaid managed care plans adopt these models, and we're also considering these models for our state employee plans. So where we have direct control, we're requiring these models, and we've been very pleased that on a voluntary basis, the largest commercial insurers have agreed to join us. On patient-centered medical homes, we made a decision to focus first on the comprehensive primary care initiative in Southwest Ohio, learn from their experience there, and now over the next few months, we want to take those lessons and translate them into a statewide strategy. On episodes, we've been working for more than a year to design 6 specific episodes that are now ready to launch, and on March 2nd, performance reports will start going out, and we'll go through that in more detail. Over the next 2 or 3 years, we want to take both of these models to scale and eventually have most Ohioans enrolled in some form of value-based payment. One of the reasons this effort is so unique in Ohio is we have a very competitive insurance market, and we have a lot of competition among our health systems. That is good news, but it also means that it sends competing signals about how to reward value. And what we need to do is align incentives. So who has agreed to work with us to align incentives? It's the plans listed here: Anthem, Aetna, Medical Mutual, United, CareSource, Molina, Buckeye, and Paramount. How have they agreed to align? We agreed that on certain areas it made sense that we standardize as much as we can across these plans. Quality measures are a good example, where if together we adopt similar quality measures, it sends a clear signal to providers around what will be financially rewarded. In other areas, it made sense to align in principle. For example, we are in agreement that where value is generated by a provider, the plan should share some of that gain back with them. But we also agreed to differ by design, to differ intentionally in some respects. For example, not setting the exact amount of gain sharing. So the idea here is to create a model that's flexible enough to standardize on key elements, but still give the plans and providers room to have conversations with each other about the exact nature of their contracts. So this is the approach we applied to the 2 payment models. I want to spend a couple of minutes talking about patient-centered medical home, and then we'll go on to the episode-based payment. For patient-centered medical home, almost 2 years ago now, we convened this group to decide an approach for Ohio on supporting patient-centered medical homes. Our first step was to review projects that are already underway in Ohio. The state supported and funded some education pilot sites to convert practices into patient-centered medical homes. There are some that on their own pursued NCQA or Joint Commission accreditation. And as I mentioned, we have a comprehensive primary care initiative here in Southwest Ohio. and some insurers had pursued their own efforts to encourage the development of patient-centered medical homes. What we saw was that almost all of them focused on improving the care delivery model, some on the payment model, only one on infrastructure, and some on supporting how to scale up and practice transformation. What was most interesting to us at the beginning of the process was that the comprehensive primary care initiative addressed all of these different aspects. So we chose it as the model to follow, learn from that, and then consider how to roll that out to the state. The Comprehensive Primary Care Initiative is in Dayton and Cincinnati. As I mentioned, it's only one of 7 CPC sites nationally. The key here is that bonus payments are provided to primary care doctors who better coordinate care. It's multi-payer with Medicare, Medicaid, and 9 commercial insurance plans participating. The practices were selected based on their use of HIT and advanced primary care recognition. And the goal of the project has been to learn from CPC in developing an approach to roll out statewide. One of the benefits of the CPC initiative is it's supported by a unique regional collaborative with the Greater Cincinnati Health Council, the Health Collaborative, and Health Bridge. We're fortunate in Ohio that we have 3 regional health improvement collaboratives, and we will rely on these organizations to help us design the state approach to patient-centered medical homes and roll out a statewide strategy. Our next step is to learn from CPC and roll those lessons up into a general approach for Ohio. We need to decide the care delivery model we want to commit to, how we will align payment to support that model, what additional infrastructure is required, and how can we scale up and support practice transformation to achieve those objectives. From CPC, we've learned that these seem to be the elements of the patient-centered medical home care delivery strategy that make a difference in improving care and holding down the total cost of care. The question in front of us is this the model we want to endorse for the state? How do we stratify risk? How do we provide better access to team-based care 24/7? How do we plan ahead for chronic conditions and preventive care? How do we improve patient engagement? All of these are priorities for the care delivery model. And once we decide on what we want to support, then how do we financially reward that model? Can we provide resources to support business model transformation for a finite period of time, particularly for small practices? Can we agree to provide resources to compensate PCMH for activities not fully covered by existing fee schedules, for example, care coordination? And really where we want to get is to agree to reward patient-centered medical homes for favorably affecting risk-adjusted total cost of care. If a practice is able to hold down the total cost of care, currently the benefit of that accrues to the insurance plan. It makes sense that the payers would share back some of that value with the high-performing primary care site. So one final note on PCMH. This kind of practice transformation is not easy. We are fortunate that the Ohio Health Information Partnership, OHIP, and 3 regional health improvement collaboratives and others submitted a statewide collaborative application seeking $28 million in federal grants to support transformation for 6,400 clinicians statewide. So we're optimistic that Ohio will receive this, and it will add to the resources that are available to support practice transformation. Okay, our second model rewards better value when high-cost episodes occur. This is the area that's particularly timely because in another 2 weeks, the performance reports related to the episodes are going out. So we wanted to make sure it was clearly understood what the content of those reports would include. Using a similar approach, we convened this team to design an approach to the episode-based payment model. In general, this is the approach that that team decided to take. The first few steps are how the system works today, and that's important. It doesn't require any new or different investment in infrastructure. Patients seek care and select providers as they do today. Providers submit claims as they do today, and then payers reimburse for all services as they do today. What changes then is on the back end of that process, we collect claims around a bundle of services, an episode of care, and then payers calculate the average cost per episode for each primary accountable provider, and then compare average costs across providers. So the idea is we look at providers in competition with each other to understand who is generating value, and then attach payment incentives and rewards to the highest value providers. When you do this, it creates a view that looks like this chart. What you're looking at here are a group of principal accountable providers. This has been risk adjusted, so these are a comparable comparison of similar cases. And you can see there continues to be significant variation in price. To the left of this picture, there are some providers that exceed what is considered an acceptable level. But to the right, there are a number of providers whose cost comes in well below a commendable level. The other thing I would point out about the model is it is sensitive to quality. Step one is identifying if providers have met a minimum set of quality metrics, and only if they do meet those quality metrics are they eligible for gain sharing. So in this example, the providers indicated by the blue bars did not meet the quality metrics and are not eligible for gain sharing, but the providers indicated by the green bars met the quality metric and would be eligible for a bonus payment back because they held down the average cost below the commendable level. So this approach achieves several really important things that we've been trying to get out for a while. One is to see variation across providers and create a way to get financial incentives directly to the providers who are providing the greatest value. Now that we have the general model, where do we focus first? We use several principles to select the models we focused on. Very important in this first round was to have things that were simple enough to be easily defined, and ideally episodes where we already had some experience and existing definitions to work from. Through a process with the design team, we selected the 6 episodes you see listed here: perinatal, asthma acute exacerbation, COPD exacerbation, PCI, total joint replacement. So the principal accountable providers listed here are the groups that beginning in March will receive performance reports with a view like the picture I had just shown you that will start to indicate their performance relative to other providers statewide. So physician groups related to the perinatal episode, the facility where a trigger event occurs related to asthma acute exacerbation, the facility where the trigger event occurs related to COPD, the facility where a PCI is performed, or the physician if it's non-acute, and in the case of total joint replacement, the orthopedic surgeon performing the total joint replacement. This is important to understand that these are the 6 groups of providers receiving performance reports. Other groups of providers will not receive reports until at a point in the future we design additional episodes. Okay, I think the best way to understand what this really means for those 6 provider groups is to go through one specific example. We picked asthma acute exacerbation, but on the website we have an equivalent amount of detail on all of the other episodes as well. So if you want to get into that level of detail, I'd encourage you to go to the Medicaid website, and we'll put that up at the end of this presentation so you can see where this information is located. The starting point for looking at each of the episodes, and this was really important to us, it was not to ask how do you get paid or how should you get paid. It was to say how do we provide care, or how can we provide care in a better way. So we didn't actually start with the health insurance plans. We started by convening groups of clinical experts and asking them how they wish they were able to provide care regardless of how they were paid. And for example, in this example, when a patient experiences difficulty breathing, there are several paths. Ideally, they would be in contact with their primary care, but they may end up in the emergency department. Their primary care physician may refer them to the ED, or they may be admitted as an inpatient stay. And then after that episode has occurred, there are things that follow up related to contact at home, contact with a nurse, or a follow-up visit with primary care. Throughout this course, there are critical moments where our decisions can add value, improving care while holding down costs. So for example, even before an admission to the ED, there's an opportunity to reduce an avoidable ED visit. And if we're able to do that and hold down the total cost of care, the value of that would accrue to the patient-centered medical home. But if a person is in the facility, there are also opportunities to reduce avoidable inpatient admissions, treat with appropriate medication, encourage appropriate length of stay, and in follow-up, making sure folks are connected to primary care in a way that they don't end up back in the facility. So the real question here is, how can we design an episode to reward these sources of value? It's complicated, but worth it. We need to be clear about each of these elements. What is it that triggers the episode? What is the time frame we're looking at? What period of time are we looking at for the episode? What claims are we going to include in both that pre-trigger window, during the event in the facility, and in the post-trigger follow-up? Who is the principal accountable provider? What are the quality metrics we want to use to see that it was a successful episode? What are the potential risk factors? And what are the episode level exclusions? What circumstances exist where it's just not possible to compare one case to another? For each of the 6 episodes we've chosen, we have detailed definitions in each category. For asthma, I'm going to flip through these quickly just so you can see how detailed the model is. For the episode trigger, we have specific code sets that identify what constitutes the trigger. We have the claims that are included in the episode. We identify the principal accountable provider. We identify specific quality metrics. These are the potential risk factors that experts with this potential episode identified as being highly related to the risk associated with asthma acute exacerbation. We use these potential risk factors then to adjust cost. So we end up, what we don't want to do is penalize a provider who sees higher risk patients, therefore their costs are higher. We don't want to penalize that provider for seeing that higher risk patient. So what we do is adjust the cost down based on these potential risk factors. And then here are some of the episode level exclusions, things that are so complicated that it makes the case really not comparable in a general way to others. So if any of these exclusions are present, we simply exclude that particular case from the comparison. So these definitions are critically important to adjust risk in a way that is fair. What you're looking at here is the unadjusted episode cost with no exclusions. And remember, we're looking at asthma acute exacerbation. So here, these are facilities where the trigger event occurs. And you can see the average cost varies significantly across facilities for asthma acute exacerbation by a factor of 7. But this doesn't yet account for things like risk that we want to take into account for a fair comparison. So the first adjustment we make is to simply exclude some cases based on some business exclusions. For example, if there was third-party eligibility, dual eligibility, other administrative issues, and we also have a list of clinical exclusions. For example, if the person had cancer, end-stage renal disease, those cases are simply too complicated to include in the comparison. Once you exclude those cases, this is the average cost after episode exclusions. From this point, we make an additional adjustment to account for cost normalization. What we do here is remove any impact from medical education and capital expenses. Once you make that adjustment, you have an average cost after removal of the impact of medical education and capital. And then the final adjustment is the risk adjustment. And here, those factors that the experts have identified as being most related to risk in an asthma acute exacerbation, we have a set of factors that apply to these. And when you make that calculation, you end up with a final risk-adjusted average cost per provider after the outliers have been excluded. So you can see in the background there the original unadjusted cost curve, and after a series of adjustments that the model requires, this then becomes what we believe is a comparable comparison of value based on cost. When you resort that from highest cost to the left to lowest cost to the right, and then compare that against risk, you can see below the risk adjustment is evenly distributed. So we think the model is generating a fairly accurate adjustment for risk, which means that we can use the cost comparison at the top now to really compare value across providers. So what this lets us do then is start looking for sources of value within the data. So for example, sticking with the asthma acute exacerbation episode, one driver of variation that stood out to us is the decision on whether or not to admit the patient into the facility. Here you can see that for the 10% of providers who were lowest cost, the inpatient admission rate is only 1% for that group. And the repeat exacerbation is very low, 8%. On the other end of the spectrum, for the 10% of providers who are the highest cost, there's an inpatient admission rate of 11%. So clearly that decision to admit is having a direct effect on the cost of the episode and is one potential source of value where the providers on the left can change their practice pattern to move into the value end of the equation on the right. Now, we run a similar view. This is using actual Medicaid data, and this is actual data that will be coming out in the March reports. And when you look at it across different episodes, you see a very predictable similar curve. This is variation across the perinatal episode. We see correlation in cost, for example, to things like the C-section rate, which varies from 0% among some providers to 100% among some providers. And the principal accountable provider here is the physician or the physician group delivering the baby. Here's the variation across the COPD acute exacerbation episode. Again, inpatient admission rates vary significantly and could be a source of value. And the rate of repeat acute exacerbation with 30 days varies from some providers who do not have a repeat exacerbation at all to other providers who 63% of their caseload ends up as a repeat exacerbation. So again, a real opportunity to understand sources of value. This is the view for acute PCI. Again, variation in readmission rates. This is the distribution for non-acute PCI. And here's the view for total joint replacement. Here, for example, you can see a greater than 200% variation in imaging and diagnostic spend. So for those that are ordering more tests, is there a potential source of value there? One thing in addition that this data lets us see, this is the same picture that was just up for total joint replacement, but now it's further broken down by the component costs associated with the episode. And before, the surgeon would have seen his or her cost, the hospital would have had a cost. Each of these would have been seen separately by the provider. What we're able to do now is assemble this, and the principal accountable provider, in this case the surgeon, actually can see what the hospital average cost is compared to others, and the pharmacy cost, and the rehab cost, and start to form an opinion around how, as a team, the total cost of that episode could be held down in a way that moves that team into the bonus range for gain sharing back from the insurance plan. So what do we do with this information? We are going to assemble this into reports, performance reports that will come directly to providers. We have an agreement from the plans listed here to get their information as closely as possible into this format. Each plan will send each principal accountable provider a report. Each provider will be able to orient themselves relative to others. And this is just the first page of the report. The detail will include case-specific information, all of the claims for an individual case across all of the different provider groups that are included in the episode. So it's a tremendous amount of detail that hopefully then will be able to be used to improve the approach to the episode in a way that gets at additional sources of value. Okay, so who is going to send reports and to whom? Ohio Medicaid will release one Medicaid report that aggregates fee-for-service and health plan claims for these three episodes: acute PCI, non-acute PCI, and total joint replacement. The reason we're aggregating those reports is because there were fewer cases, and because there were fewer cases, it did not make sense to send individual reports to everyone. But then in the next group, there were a number of cases. So Ohio Medicaid fee-for-service and each of the 5 Medicaid health plans will each release a report on their own Medicaid claims for asthma acute exacerbation, COPD exacerbation, and perinatal. And then the participating commercial plans will each release a report on their own claims for at least 3 of the episodes listed above: acute PCI, non-acute PCI, total joint replacement, asthma, COPD, and perinatal. Reporting will occur quarterly for 1 year, and payment will not be tied to reports until at least January 2016. This is an important element of the design. We did not want these performance reports to be a gotcha where suddenly providers' payment was related to a report that was new to them. So the idea is that the performance reports go out on a quarterly basis for a year, giving people time to change their practice patterns and move into a gain-sharing mode so that then when we attach payment to this at a point in the future, all providers have an opportunity to benefit from that. In terms of next steps for the episode-based payments, this just repeats what I've said already, that on March 2nd, performance reports will start going out. About half of the plans on March 2nd and the other half a week or two later. We are now in the process of convening the payers to identify the next 7 episodes. And then, based on what episodes are selected, we will convene clinical advisory groups with experts who actually provide those episodes of care to design each episode. The idea is then that in January next year, we would roll out the second wave of 7 episodes. And then, back to our discussion on patient-centered medical homes, we will convene a PCMH planning team to review lessons learned from a comprehensive primary care initiative. We will define a PCMH approach to roll out statewide, and we will make recommendations for regional implementation, all of these activities to occur over the next few months. Okay, so that's a lot of information to go through, but it is all and more posted on our website. Here you're looking at the Health Transformation website, and I've indicated there where our patient-centered medical home charter for payers is, our episode charter, and this overview presentation. But specific for providers, this is probably the detail you want. This is the Medicaid website. You see the URL at the top there. On this site, you have access to information about detailed episode definitions, business requirements, code tables, and specific information about how the risk adjustment was accomplished for each of the episodes. So I am going to pause here. I'm going to bring John McCarthy into the discussion with me, and we want to open this up to any questions.
Just as a reminder, for those of you who want to ask questions, we are using the question feature in the webinar toolbar. And the first question we have is about PCMH. PCMH does not appear to be limited to primary care. Is that intentional? Would it be allowable for certain specialists to create a PCMH for certain for individuals with complex chronic illnesses?
So this is John McCarthy. That's a good question. We haven't completely finished the design for PCMH, and that is, you saw in some of the slides that we showed of how we would be rolling it out. I mean, the original design that we had contemplated was just in primary care, but as the PCMH has been rolling out across both CPCI and the nation, this question has come up. So I think it's something that we're open to and would love to have further discussions on. So now we're going to our next question.
The next question is, how is cost determined for episodes of care? Is it what the provider charges or the determined cost of the service?
This is John again. That is a question that has come up quite a bit, and I wanted to make sure we're clear about this. Cost is defined as in the Medicaid reports of what Medicaid paid. So it's not based on charges. It's actually based on Medicaid payments. So it's thus cost to the Medicaid program or payments from the Medicaid program. I know in a number of our meetings I've had to stop and make sure we're talking about that because entities have said, well, you don't know what my costs are. That is correct. It is defined as what was paid.
The next question is, for the second 7 episodes, is the plan the same as the first? Data for 1 year and gain share year 2?
This is John again. Yes, the way that we were planning to roll these out until we get really good at these is that we would be looking at 1 year's worth of reporting so that if there's any issues with the report, things that we've missed, items that just don't make sense, we can catch those things and then set payment for the next year. One of the things I wanted to point out, though, around the episodes is that the way the lines will be set for the gain sharing is that those lines will be set a year in advance. So it's not like we're going to grade these on a bell curve, so many people have to be above the line, so many below. We'll set the lines in advance so everyone will know where it's going to be in the following year, so everyone could come in underneath and be able to participate in gain sharing.
Next question. How will you recognize the appropriate value-based payment innovations may be already implementing? For example, ACO, CMMI episodes, capitation with commercial-based plans?
So I am assuming that this question ties to one of the Medicaid provisions in our contracts with our managed care plans, which is that all payments 20% of payments need to be value-based by 2020. And so the question has come up, well, does this account for all that 20%, or will we recognize other value propositions? From our standpoint, we want to recognize all value propositions. What we had seen, though, was there wasn't a movement towards them as quickly as we would have liked. There are some already out there that are at full risk, full capitated risk, which we clearly would say that is something we would recognize. And then for then SIM would just be the floor for which then we would be looking at value-based. And we would be looking at other ideas then from there. But what I want to make clear, and I've said this before, is that the Department of Medicaid is not recognizing simple gain sharing as a value-based proposition. We get a lot of providers that come to us that they're willing to share in savings, but they're not willing to take the risk on the other side. And so that has been a part of this model, and any model that we would recognize is there has to be risk on both sides. Now, again, I am answering that for the Department of Medicaid and the managed care plans and how we oversee them. This does not apply to the commercial plans.
And this is Greg Moody. This was the source of a lot of conversation at the beginning where I think we all had wished we could jump straight to something like an accountable care organization, but recognize the reality in Ohio's marketplace where there's a lot of competition among health systems and health plans. We didn't want to put the state in the position of refereeing who would win becoming the accountable care organization. It just seemed like the market here was not quite mature enough to be able to make that decision. So it's why we dropped down a level and focused on the basic foundational building blocks of what an accountable care organization would need to have, which we believe, and we believe there was consensus on, better primary care, and when high-cost episodes occur, better value there. So the idea was to build out those building blocks in a way that we're hopeful others will figure out how to assemble those into accountable care.
Next question. Have payers indicated a greater interest in expanding episodes to commercial populations?
So in our meetings that we've had, this topic really hasn't come up. What we've been talking about is in order to ensure that providers and payers are not overwhelmed, we would be picking episodes, even as we go forward, all together. And when we're picking episodes, as you saw with the ones in the first round, we would be picking episodes that apply to both Medicaid and commercial payers. And so some are more relevant to one side or the other. And that was going to be our goal as we continue down this path. And so there are episodes that we all will be reporting on, but it will have a larger or smaller impact on each side.
Next question. Is there any relationship between the PCMH model and the episode model? Are they meant to work together?
This is another question that's come up, and when people were questioning some of the episode-based models, specifically on acute exacerbation, and you saw on the slide that Greg showed that in the first box, the person could take two different paths, right? One was to the hospital, the other one was to their primary care provider. So the way this works is the episodes and PCMH work hand in hand in the fact that as we move forward, and if that PCMH would be keeping that person out of the hospital in the very first place, that wouldn't become an episode. And total cost of care then under that PCMH model would not have any costs associated with the hospital. It would all be on simply the provider side. On the other hand, if the person actually did go to the hospital, that would be counted in the total cost of care for that primary care provider, that PCMH. So that's how those two things are linked together. And then when you're looking at the episode attached to that on the acute exacerbation, you see in there we're counting time after the person leaves the emergency room. Again, you're tying that back to the patient-centered medical home, total cost of care, but also if that person relapses or something happens and there's another acute exacerbation in those 30 days, that counts back towards the primary accountable provider. So it puts back into play that relationship between the primary accountable provider and the patient-centered medical home.
Next question. I noticed that the physician costs for joint replacement did not vary much. Thus, the differences in cost were due to hospital and/or rehab costs. This will put the onus on the physician to try to control the hospital costs. Will there be any suggestions or tips to the doctors how to do this?
So you're correct. When we were looking through this data, that's where we saw the variance across the providers. And actually this came up in a number of our meetings, in our clinical meetings, and you saw the clinical work group that was working on this. We are going to be working with all the associations to enter into these discussions to help physicians move along this path. But what we found is that physicians often feel that they are unable to impact those costs, but in reality that they can impact those costs. One of them is there a different hospital you can choose? In your area, are there 2 or 3 hospitals to choose from? That is one question. And then the other one is, especially in the rehab side, is how well is that provider who's providing rehab doing? Should referrals be going to a different provider? You as a physician will be getting all that detail as we were talking about on the claims and where the costs are, and in talking to some other physicians of who's doing better and who's doing worse, and starting those communications.
Yeah, and this is Greg. This is, I really appreciate this question, because this is exactly the kind of constructive tension we're trying to introduce into the situation, where today the answer is it doesn't really matter if you see the price of the other inputs because there's no effect one way or the other of changing them. If you reduce the rehab cost, or if you reduce the pharmacy cost, or you reduce the hospital cost, the surgeon is simply paid the same amount. Now, in order to have access to a bonus, and remember, this is not in this case taking something away from that surgeon's current payment, but in order to get access to the bonus, it will require taking a more direct role in understanding the total cost across the team, and that's why choosing the principal accountable provider is so important. Who is in the greatest position to influence the other members of the team? And that sensitivity to that is what went into the selection of that particular principal accountable provider.
Next question. Do you imagine replicating a CPCI model anywhere else? Would it be scaled to include services providers that involve specialties or large health systems?
Yeah, this is Greg. The idea is to look at the lessons learned in the comprehensive primary care initiative, primarily related to the care delivery model and alignment of how to attach payment incentives to that better model, generalize that to take statewide, and ideally, eventually, make that model available to all primary care throughout the state of Ohio. Now, as a practical matter, the way patient-centered medical home infrastructure works, it really takes a community grassroots effort to commit to getting the kind of infrastructure in place you need to make this work. That's why we're really looking to some of the regional health improvement collaboratives that already have a head start on getting communities to think about what it takes to build the kind of infrastructure you need for your primary care to be talking to health systems, for example. One of the key decisions we'll have to make is which community do we roll out to next. Ideally, I would like to see that be an urban community that's ready for this right now, but also maybe thinking about rural Ohio, and is there an opportunity to adapt the model in a way that lets us get better primary care capacity into some underserved areas. But those are the sorts of design questions that we'll need to address over the next 2 or 3 months.
Next question. The recent loss of Medicare parity and payments for Medicaid, even with the increase of the 2012 Medicaid payment, will mean a significant cut in payment to primary care. How will a Medicaid PCMH model offset this?
This is John. The Medicaid PCMH model is not designed to offset that. That was a federal rate increase that was put into place that the feds ended. It is up to them if they want to put that change in there. Now, having said that, as you pointed out, we are making some changes in our reimbursement rates. We're proposing changes in reimbursement rates through the budget. And then additionally, we will be looking at what is the proper amount to be paying for in the patient-centered medical home.
Next question. The bundled episode program has an incentive bonus payment for certain primary accountable providers. Is there a penalty for the higher cost providers?
So the answer to that is we still have to decide of how this is going to be rolled out, but the short answer you saw in the design is that there would be, at that top level, if you were above the top line, in essence, a payback model. We have not set, we at fee-for-service Medicaid, nor the health plans, nor on the commercial side have had any discussions around how those would be set. That is one of those items that Greg talked about earlier that we are saying that is left up to each payer individually of how they're going to set that. So I am not, as the Medicaid director, going to tell the 5 Medicaid managed care plans how to set those lines. I will be making that decision on fee-for-service. That hasn't been done yet. As we were talking about, we want to get the reports out and then make sure the reports are right before we set those lines. They will be set ahead of time. You'll know where they're at. And then we're going to do a lot of work on that to say, well, then what is the payback? Is there a limit to how much is paid back? Is it a percentage of what's over that line? Is it 50%? Is it 10%? There's a lot of those details that still need to be worked out that is going to be in the work over this year.
Next question. What efforts do you envision to improve population health and emphasize primary prevention?
Well, this is Greg. In our test grant application, the first section is on population health. And the idea is that we shift away from the current preoccupation with disease treatment and increasingly try to understand strategies to improve overall population health, which orient the system heavily toward primary care. So the selection of focus on patient-centered medical homes is specifically tied to this idea of building the community infrastructure we need to really improve population health outcomes in a meaningful way. In addition to the payment innovation activities, in the governor's budget, we're also introducing some other supporting activities. For example, regional public health planning and better alignment of hospital community benefit plans with regional population health priorities. The idea is, at a community level, what are the population health priorities, and how can we bring to bear all of our resources on moving indicators in the right direction, one strategy of which then is our payment reform to support better primary care. So we really see it as a complete and complicated set of activities, one important element of which is changing how we pay to reward value in that regard.
Last question. Who will receive the reports for hospitals?
This is John, and I want to point out one of the things in here. The way the reports are going to be put together is they will be posted to, for fee-for-service Medicaid, to the MITS portal. And so they won't be sent out to you, they won't be emailed out. Whoever goes to the MITS web portal, provider portal, when they log in, there will be a new panel there that a person will be able to get the reports and download the reports. Each of the plans, we've left it up to them how the reports will be sent out, but I know the Medicaid managed care plans were taking a similar approach that Medicaid fee-for-service is, and that is those were, in the beginning, those reports will be posted on their portals.
All right, well, thank you, everybody, for your attention. We understand that in an hour there is no way to address all the questions that might arise. I would encourage a couple steps if you have additional questions. The first is to go to the website that's currently shown on the webinar page, where a lot of this detail is posted, and it really is a tremendous amount of information. We've tried to be as transparent as we could in laying out these details. However, if that doesn't answer your question, I'd encourage you to connect with the leadership of whatever association most directly represents you. We've tried to involve the leadership of all of the various associations as we build out the models. And of course, you're welcome to contact us directly. On the OHT website, there is contact information, and we would be happy to connect with you to answer any questions. Understanding that this is new, it's fairly big, and it is going to be essentially sorting itself out over the next year. My first critical focus is on, does the model seem to be working well? If yes, then identifying those commendable levels of performance that John was talking about midway through this year, so that then providers have a few months to understand where they're positioned, so that by January 16, when we're attaching payment incentives to performance, we want there to be no surprises at that point. Okay, thank you for your attention. We feel we're on a good track here for the state of Ohio, and appreciate all of you who have participated in this process, given us your very good advice that's allowed us to get this far down the path. Thank you.